medication that is available to patients who are having issues either most of the time they're going to have issues ovulating, and that's why we give these medications. The idea behind this and your mechanism is through that increased output, so that your pituitary gland is going to increase those gonads, increase the estrogen, and it's going to say, hey, I want to now produce or have that woman make and ovulate as much as I can get her to in a short period of time. So there are certain days that we will have them take these medications depending on where they are in their entire like ovulatory cycle. Okay, so when we're looking at our clinical use of this is for somebody who they have been trying to become pregnant, they can't become pregnant. Let's say they don't want to do anything invasive yet, and they just want to see, hey, can I take this oral medication, and they want like a cheaper route than us doing something more invasive like artificial insemination, things like that. This is the route that we will try first. So ovulatory failure in those women, and then when you're looking at your men for your off-label use, if they have infertility, you can try this. Not guaranteed that it will work, but we have seen some data that shows that it may potentially work. So that's why you see unlabeled and not well studied. No more than 3 courses recommended. So essentially what that means is that they're going to have 3 months to try this medication, and what they're doing on the 5th day that they are ovulating, so they will be tracking their ovulation. There's different ways that you can do that. There's strips that you can buy. It kind of look like pregnancy tests, and they would urinate on them every day to see if they're in their ovulation. People have trackers on their phones. Sometimes those are not accurate at all and they don't work. So it depends on your patient. If they do the strips and they figure out exactly where they're ovulating, they can use the trackers on their phone to sync it up with their actual ovulation that they're having based off of the strips. But if somebody is coming into you because they cannot become pregnant, that's the first thing that I tell them: get ovulation strips and see if you're actually ovulating when you think you are, because that is probably why you're not getting pregnant, because you're not ovulating. So on the each course is 5 days, and they're starting on the 5th day of their ovulatory cycle. I usually don't make you remember things. This is in bold because I want you to remember whenever they're doing it. Adverse effects, sometimes they'll have these visual disturbances. They can have those vasomotor symptoms kind of occur where they feel like hot and flush. But again, because this is like a burst of medication that's only happening during their ovulatory phase, this isn't something that, these adverse effects aren't things that last for a very long period of time. And then looking at your bigger adverse effect, the medication is effective. What can happen is they may release more than 1 egg, and more than 1 egg can then become fertilized, and then they can have more than 1 child. Okay, so they have to be ready to face the possibility that maybe they're going to have, twins or triplets, or however many children, or decide, hey, I don't want that many, I just wanted 1, and decide, well, now you can't decide, but this was a big deal with, you don't know what you're going to get, you don't know how many eggs are going to be released, okay? So that is a big side effect, adverse effect, that they would have to live with for the rest of their lives if they use this medication, so just make sure that they're tracking that. Aromatase inhibitors. So when we're looking at this, very good for breast cancer, especially if it is estrogen dependent, because you see that it is an inhibitor. Off-label, you can see that we use it for ovulation induction, but for the most part, this is used in our patients who have breast cancer. Looking at what it does is it's going to stop that estrogen by blocking the aromatase. So if you kind of look down here, this is what is converting your estrogen. So therefore, negative feedback is going to shut everything down for us. You see the medications that we have available: your letrozole, anastrozole, and your zimastane. All of these are oral options. They are fairly reasonably priced, not expensive drugs that your patients can take. And again, the one that we typically see are these top 2, so your letrozole and your anastrozole are the ones that we typically are prescribing more often than not. Looking at your adverse effects, different pains and stiffness due to the mechanism of action that we'll see, talking about your bones and affecting them. So that's why you see that osteoporosis, because again, we're working with that estrogen. Hyperplasia occurring again in the endometrial hyperplasia. Same thing, because we have the estrogen, so you see how these adverse effects, anything that starts to mess with certain hormones, they look exactly the same, regardless of which drug class we're talking about. And then you have your ischemic heart disease that can occur. Contraindications would be any of these underlying conditions that we see, or some people are actually allergic to the medications and they will figure that out whenever they take them. Your drug interactions that you have, you see estrogen, so adding on estrogens to this, tamoxifen, and then your methadone. So when you're looking at your estrogens, if you think about this, now you have your estrogen with your aromatase inhibitor, and now it's trying to figure out, okay, how can I work? I have more estrogen here. So your effectiveness of your aromatase inhibitor is going to be decreased. Your tamoxifen, same thing, your tamoxifen is going to decrease the effectiveness of your aromatase inhibitor. And then looking at your methadone, you'll see now that you're going to have a higher concentration of your methadone, which we already know that's going to be problematic. So again, a lot of your issues that you're going to see here is because we're losing we're decreasing the levels of our estrogen. So your adverse effects kind of line up with that. Looking at your progesterone antagonist, so again, exactly how they sound, inhibiting the activity of your progesterone, and then looking at your glucocorticoid activity is going to decrease that as well. We have our two options here, your mifepristone, two different brand names, right? Mifeprex and Korlym. They're used for two different indications. So when you're looking at your mifeprex, this is for your termination of pregnancy up to 70 days of gestation. Now, hot topic on using this or not, but this could be sometimes if somebody was having a miscarriage, whether they have an abortion, sometimes this is where you will see those medications being used. And then your mifepristone, this one is more so for your patients who have Cushing syndrome and they have the high levels of glucose, so we're using this to treat the hyperglycemia that they're having. So when we get to using this is very much so like a last line thing when we're talking about Cushing's, because they were either not a great candidate or their surgery failed. Like, this is reserved. This is not the first thing that we would try to do. We can also try to see where we will use this while we're waiting on someone to have surgery. Okay, so just kind of keep this in mind. This is not the main thing that we would use in this disease state at all. Adverse effects, looking similar, nausea, vomiting, diarrhea, appetite may go down. Again, those pains and the stiffness when we're talking about the muscles and the bones kind of hurting, and then that hyperplasia. Contraindications that you see, this is going to be more so because of what the drug actually does. You're going to see a lot of cramping. So that nausea, vomiting, and diarrhea is from the cramping that is going to potentially occur from the actual drug, right? Because if you think about something where you're trying to increase contractions, right? So when you see this IUD, or if they're pregnant, that is because it can potentially make them dislodge their IUD from the amount of cramping that they have, which would be very painful for them. And then the same thing with pregnancy. If they are pregnant, it could potentially make them miscarry or abort the baby. So that's why you see those as the big contraindications. The vaginal bleeding, we already kind of talked about that. Interactions, again, we have some CYPs that are being inhibited, and then you see also PGP, which we don't see often added here. And then grapefruit juice, they would have to drink quite a bit of grapefruit juice, but just understand that it is something that could potentially interfere with your progesterone antagonist. Looking at our androgens, so testosterone therapy is a very good option for several different indications. Most of the time when we hear about testosterone therapy, we think about low testosterone levels in a lot of our males. Most of these preparations that we have are not oral, but now we are seeing ways where drug companies are manufacturing the medications to where oral options are becoming available. So we do see those now. So we have IM, which is like the main route, one that we are very familiar with dispensing in the pharmacy, as well as topical formulations. You also have sub-Q, the oral, like I told you, and intranasal. Now, as more oral options become available, depending on how often these preparations or formulations are being prescribed, you can see where some of them will come off the market or on the market. So this keeps fluctuating as far as which formulations are available based off of technology and kind of us discovering new ways to deliver medications. Looking at our clinical use whenever we're talking about our androgens. So we're looking at your osteoporosis and your anemia. This is essentially saying, hey, my patients are older, natural way of kind of what we're thinking should happen postmenopausal, right after menopause, that estrogen level is going to drop, and therefore you can see the osteoporosis happening as well. Looking at your males, you see that you have your low T, which is what we were talking about. If some patients have issues impotence, okay, you'll see it used there. Hypogonadism, and especially if someone is trying to reproduce, we can see sometimes where we may have to add on therapy for them as well. And then if there's a growth delay, we can see this used in that situation as well. For our women, we will sometimes use this with estrogen depending on what their estrogen levels are, but you see your hypopituitarism and then your cancer or anybody who has any type of endometriosis, we could potentially treat with this. When you're looking at your unapproved use, this is also why testosterone was getting a very bad rep. And that was because people were using it to kind of improve like their athletic performance. So that is not FDA approved or an FDA approved use. So you as a provider just make sure that you are properly screening your patients whenever they come in. We've been having a lot of younger people like in their 20s coming to the pharmacy now on testosterone. So just, again, just do your due diligence. Not to say that they don't need it, but just be very aware and cautious of what they're asking for it for, especially if they're like walking in and they can't put their arms down to their side. All of these, regardless of the formula, that's how I think of them. Like when people walk like this, I'm like, put your arms down. I just want to see if you can do it. Just try real quick. When you're looking at your testosterone, all of these are going to be controlled medications. So they are all Schedule 3, regardless of how they are prepared, they are all Schedule 3. And then adverse effects. So when we're looking at this, there are several different things that could potentially occur when we're talking about using testosterone. Most of these occur whenever they are being abused, and not so much so whenever somebody is taking a normal dose of the testosterone. So high blood pressure, their LDL levels may start to become out of whack. You can see that they can have PEs. There used to be a black box warning saying that there was an increased risk of cardiovascular issues in males who were taking testosterone. And so on any formulation of testosterone, you would see a black box warning. Recently, there was a trial called the Traverse trial, and this happened in February of this year, where the FDA removed all of the black box warnings from the testosterone, saying that there is not an increased risk of those cardiovascular events. And now all of those package inserts, so like that long thing that I showed you, all now have the results from that trial also in them. So that probably made it a lot longer. I'm trying to find one. So again, this is something that is newer, so you will hear some providers very cautious about it, but just understand that that is something that was recently removed from all of that labeling, and we don't have it happening now. Your adult males, prepubertal males, females, you see that we have different kinds of effects going on here. And again, it depends on the dosage that they're taking. So we just said that if somebody is having hypogonadism, that I could treat them with testosterone, but you can also see where it can cause a decrease in the amount of sperm that they have available that are viable because they could be abusing it, okay? So that dose really matters. Looking at your prepubertal males, understanding that you can kind of see a decrease in their height, okay? So you want to make sure that they have that they're out of puberty. Hopefully you're letting their body kind of regulate before you deem that they have low T. And then looking at your females, if they're abusing this, you'll also see that their features will become more masculine, and they will start to experience more acne and like skin changes. Muscle mass changes will also occur within their voice. They can start to lose their hair in the same way like a male would, so that male pattern baldness. So again, just kind of understanding that yes, we can use it in females, but those adverse effects, especially if that dose is higher. Okay, this is also, again, things that you'll typically see when someone is abusing it or using it off-label. Even their genital area will change, like of what it's supposed to naturally look like. Okay, so again, this is with your higher ends of dosages with these patients. Okay, your favorite charts. So this is just telling you, here are all of the different types that I have, right? These are all of the different testosterones that I have. I want you to make sure that you are aware of the different names that are available. And then look over at your comments. And that's all that we're looking at when we're talking about these, because that's all I need you to know. So when we're looking at our IM formulation, the big thing that we need to make sure that we're watching out for, if you prescribe an IM formulation, please make sure that you prescribe, what am I going to say? Needles. We get these and the patient is like, well, what am I? They will come back, right? We're thinking, oh, you have needles at home because your doctor probably prescribed them before, you're just picking up a refill. And they're calling us because they're like, well, I poked a hole in here and I'm trying to get it out, but like, do I just rub it on? Because it says to inject it, but I don't have anything to inject it with. Okay, so you don't have needles, right? Okay, cool. Come back and let's call the doctor. We'll get your prescription for your needles, or go to the store and buy needles. Don't tell anybody to go buy anything. They're gonna be like, I serve in the military. You want me to go buy something? I get my stuff for free. All right, come back. Just come back. So please, 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 anytime you have somebody injecting something, prescribe their syringes for them, because they will get creative in trying to figure out what to do. Also, make sure that you tell them not to reuse them. We have a lot of people who try to reuse their syringes as well. Okay, big no-no. And people will share them. Okay, so just be very, don't think that they know better. I'm telling y'all, oh, okay, that was interesting. So make sure that that's the big things that you're looking at there. And then your, I also tell people to try to rotate their sites. When you're prescribing this, the other thing, depending on the dose that you give them, please make sure that you're adjusting your and accounting for the amount of milliliters that are in each vial, depending on what we have available. Sometimes we will have 1 milliliter vials and they're able to get a couple of doses out of that. Sometimes we may have a 10 milliliter vial. What happens is, depending on which one you order, they then have a bunch of extra testosterone that's lying around for like months worth. And they're getting it every 3 months, but they already have like several vials stacked up. So make sure that your day supply matches with what you're giving them, okay, like in that vial. You have an implant option that's available to them. Then looking here at your transdermal, the big thing here, making sure that they know to not apply it to their genital area. Make sure that wherever they do apply it, that they cover it. People forget that they're putting it on their arms or what have you, and they're playing with kids, little kids, and they're rubbing against the testosterone, and they have no idea. They forgot, because people like to walk around their house without a shirt on. That's a normal thing to do. But if you have testosterone that you're using transdermally on your skin, then you need to make sure that you're covering it up so that somebody is not brushing against it, your wife, your kid, whatever, right? Because now she might start to look masculine with our adverse effects, okay? It's going to be your fault. Looking at your oral options that you have available, remember, several different ones are starting to come out. This is becoming more popular. We did not have a lot of these before, but when you're looking at this, just see that you can also have sometimes where you can get some weight gain in your younger kids. So just look at this, and also when you're talking about that cryptochidism, is where essentially their testicles never fell, and so we can sometimes use this in those young males to try to help with that as well. Okay, so good options that we have, and the fact that it's an oral option is also good for them as well. And then your intranasal option that you have, so they would just inhale it their testosterone. So depending on what they're willing to do, we're trying to limit contact, and that's all going to be based off of how we are giving it. Okay. Danazol, another oral medication that you have. This is an androgen derivative that works by suppressing the pituitary from releasing the FSH and the LH, which will ultimately affect the testosterone levels that we have available. So if we can decrease that, then we're going to try to decrease some of those or affect that level. When you're looking at your endometriosis, we can see it used there, but when we're talking about using it when we're talking about using it for our endometriosis, again, because it's an androgen derivative, some of our patients who have this, most of our patients, they experience side effects that they don't like from this medication, so just not used very, very often. Looking at your GnRH analogs that we have, so this is what we were talking about when we were looking at prostate cancer. So with this, that's why we don't see these used as much anymore, because those are a little bit more effective. And then you see also that I have good bioavailability when I'm looking at this, comparing it to my testosterone. But again, remember that that's starting to improve now with us making and manufacturing more oral options for your testosterone. Looking at some of our anti-androgens and androgen antagonists that we have, when you're looking at this, these are essentially, again, doing the same thing with stopping the effects of our FH and our FSH and our LH. And so when we talk about this, for the most part, you'll see that we're using it in BPH. There's also several other options that we can use to treat. So endometriosis, prostate cancer, early puberty, so all those things that we have talked about previously, we can also see this used here. But BPH is typically where you're going to see these used. Making sure that you're understanding that we have two different options, and these are two different classes of medications that can be used together because they have two different mechanisms. So when you're looking at your alpha blockers, this is stopping the contraction at the neck of the bladder, and therefore it's allowing the patient to be able to use the bathroom and decrease the symptoms that they're experiencing. So you have your terazosin, your doxazosin, your alprazosin, and your tamsulosin. And then you see that some of these, when we look at them, we have different uses. So whenever I said alpha, your ears should have perked up because we talked about alpha all the time when we're talking about hypertension, right? So I can use this for BPH and I can use these for hypertension. When I'm looking at my alprazosin and my tamsulosin, those are specifically for BPH. My tamsulosin is more specific because it's targeting the alpha-1A receptor. Okay, so it's more selective. So if I'm more selective, most of the time, that means that I'm going to have slightly less adverse effects whenever I'm looking at it. And again, you can use these together. When you're looking at your 5-alpha reductase inhibitor, this one is going to block that reductase, which results in DHT, which is why you will sometimes see prostate growth. So this is trying to say, hey, if I block this 5-alpha reductase, therefore I can decrease the amount of prostate growth, which I don't want to happen when somebody has BPH. They already have growth in that area that is now affecting them and likely how they use the restroom. So you'll see finasteride being used in this population as well. And like I said, you can use both of these together depending on your patient's symptoms. Looking at the medications that we have available, and going into more detail about these mechanisms. So we talked about our mechanism with your finasteride. You see that there's two different brand names. You have Propecia and you have Proscar. Depending on what you're using it for is going to, again, change that brand name, so marketing. So when you're looking at Propecia, this is for alopecia, so the name kind of makes sense. So you're using it for your male pattern baldness. It is not for women to use that unless they abuse their testosterone and now they have male pattern baldness. So they shouldn't be, for most part, this is for males. And then when you're looking at your finasteride, again, this is for your patients who are having that symptomatic BPH where they're not able to go to the restroom and they're needing some relief so that they can use the restroom or completely empty their bladder. Okay? So finasteride is two different names. I can use it for alopecia if I'm talking about Propecia, only in males. And then my finasteride or my Prascar is to help them use the restroom if they have BPH symptoms. Okay, same exact drug. And then this is more detail about that mechanism. So when I was telling you it's going to stop that 5-alpha reductase, which is essentially where this is going to convert that testosterone into that DHT, which is what we don't want, because it's going to cause that prostate to continue to grow, and it's going to make their symptoms even worse. So what I'm trying to do is I'm trying to stop the formation of the DHT. Okay, so if I block my 5-alpha reductase, I am stopping this, and therefore I am decreasing potentially the growth that they are experiencing. All right, your finasteride, again, treatment for your BPH, so your patients who are having symptoms, they can't go to the restroom. We already said that we can use it with our alpha blockers. And then for your patients who have, and your women who have extra hair growth or hirsutism, you'll see where you can use your finasteride in this situation. Haven't seen this used in, for this indication very often, but again, off-label use that you could potentially see it used in. Because of those decreased levels of your testosterone, you can see erectile dysfunction, different types of issues happening with their performance, their sexual performance, so just kind of keep that in mind in their libido as well. Not safe for use during pregnancy, so much so that even like in the pharmacy or even at home, if there is someone who is pregnant, they should not be touching any of these pills or be exposed to the contents on the inside. So the reason why it says crush is because the outside usually has a coating, but even in the pharmacy, we will have them use gloves, or we won't even let them feel it at all, because when you pour the tablets out of the bottle, sometimes like powders and stuff come up, so we usually won't even let them around it. So just make sure that they are not being exposed to that, and that also includes if they are pregnant or trying to become pregnant and they have a spouse who is taking this medication, because it will be in their semen. Also trying to make sure that we're avoiding that as well, okay? Because that medication is going to also be in that, yes.
Is that because it's a testosterone?
Yes, and because it has the testosterone in there, it's going to, and you don't know. So when we're talking about the kids, I'll talk to you on the break to explain it a little bit more. But yes, we should not, and there's several drugs that we have in the pharmacy where it's like a list of like, hey, if you're pregnant, don't touch any of these things. So I'll talk to you about it in a minute. Sexual dysfunction. Uncomfortable conversations that your patients are going to have to come and have with you about this. And y'all laugh when we talk about it in class, but when y'all get out there in phase 2, you're not going to laugh about it. You're going to sit there, you're going to listen to your patient, you're going to fix them, okay? So let's talk about some of these things that are kind of uncomfortable for the patient and then a little bit uncomfortable for you too. So when we're talking about an erection and somebody getting an erection, essentially what's happening is that nitric oxide is supposed to go and allow the male to achieve an erection. What you'll see is that the smooth muscle is going to be relaxed because of our CAMP, so we're our CGMP, so we're relaxing our smooth muscle, and therefore I can have increased blood flow, and that's how someone gets an erection. So when we talk about like beta blockers and things like that and how they don't get an erection, it's all because I have probably decreased their blood pressure and their blood flow, right? So that's how sometimes we will see that occurring. So when we're talking about this bottom part, just understand that it can happen. There's several different reasons. I would tell you what's going on. Also, you'll have some patients who have had some type of traumatic injury occur to where they could have had an issue with their spinal cord and things like that. There's different medications that we can use to treat those patients. It's not the same as like somebody who is just having regular erectile dysfunction, okay? Because now they have nerve damage that could be potentially not allowing their body to send that signal for them to achieve an erection. And so we'll talk about some options that are available to them. So increased blood flow because we have the nitric oxide, which is going to make the CGMP, and that's how we get our erections. When we talk about the causes of erectile dysfunction, there can be several different reasons why this happens. We can have our medications, so we can talk about some of these different medications, our diuretics. We can talk about our antidepressants. Remember, that was a big side effect. Now I always say, like, hey, make sure you tell your patients, because they're already sad. You're going to make it worse if they wanted to have sex, because now they're going to have issues performing, and people want to know that before they get into that situation. So this is why we have those conversations. So I do need you to remember the underlying issues that could be happening in regards to the medication. Arthrosclerosis, just because now that blood flow is not able to flow as freely anymore because everything has gotten hardened. And then you see smoking, alcohol, diabetes, things like that, all those other comorbidities. So what I'm worried about you understanding here is which medications are likely to cause erectile dysfunction. So when we're looking at treatment for erectile dysfunction, we have our PDE5 inhibitors, and what they do, they inhibit PDE5 so that your CGMP can stay around for a longer period of time, and therefore you can have more of that smooth muscle relaxation and achieve an erection. With these medications, you do need stimulation for them to like work and then wear off. So this would be a situation where you would want someone to say like, hey, you need to be in the situation to use these medications, because we also don't give them a lot of them, right? So I think now they're allowed 12 or something. I think it went up. It used to be 9, but I think now they're allowed 12 every 3 months, okay? So that's all they have is 12 pills to use in 3 months, okay? Some of your patients will be like, oh, the 25 milligram isn't working anymore, so that you can prescribe them 100 and they cut that thing up. They get real slick. So just, you know, don't be mean, let them do their thing, okay? But just be aware of that. There are a lot of limitations when it comes to how many they're allowed to have. So look on your TRICARE formulary lookup tool, and it will let you know what their limitations are as far as how they can get that. Some people will still ask you for a prescription, and they will buy them out of pocket, like not through their insurance. So they'll get their ones through their insurance, and then they may also want to use that prescription to go to Walgreens, CVS, what have you. They know TRICARE won't pay for it, and they will pay for them themselves. So again, clinical use that you have, erectile dysfunction is the biggest one, but we can also use it for PAH, or pulmonary arterial hypertension. The dosing is different and it's more frequent. They do ask you for prior authorizations. They do try to make sure that the person is not using it for something else for the erectile dysfunction. So you will probably have to fill out paperwork when we're looking at PAH or BPH. Now, your durations. I need you to remember how long these will work for. So when you look at your adenofil, your sildenafil, and your vardenafil, these all last for 4 hours. And when you look at your tadalafil, this one is lasting for 36 hours. So like think about it like tada, like a long time, right? 36 hours versus 4 hours for everything else, okay? And then your adverse effects. Because of the mechanism and how we're blocking things, you'll see sometimes where your patients will have flushing, they'll have hypotension. So when they come into the ER, you'll see sometimes where y'all are asking certain questions because we don't want to further cause hypotension in our patients. But a lot of times, they're not going to tell you. They're going to hold on to it. And I've had an attendant, he's like, if you don't tell me if you took it, you could die. And the person was like, okay, yes, I did. Because he was like, no. And he was like, I see it on your profile. Like, are you sure? Like, you haven't taken it. Like, let me know because I'm just trying to ask you. And I was like, no. He was like, okay, if you don't tell me, you could die. And he's like, okay, I took it. And he's looking at all the women in the room like, we don't care. You about to die, you better tell us the truth. So, like, you sometimes, if you look at the med rec, your med rec is going to help you sometimes more than your patient because they're embarrassed. They don't want to say that. So you need to make sure that you're doing your due diligence, that you're letting them know, like, I see you have it, let's just rip off, like, let's talk about it. Because I need to make sure that these other meds aren't going to be worse for you. So those are the big things here. Your vision changes. We can also see that happen. And then the priapism, or that long erection, longer than they would like, what happens is they would have to come into the hospital. You would drain the blood out for them because they never lost the erection when they were supposed to. Okay, so you do see that happen sometimes, but you can fix it for them. Your medications. Here are all the medications that we talked about. Remember, these are 4 hours. Ta-da! It's 36 hours. And then I just want you to pay attention over here to the comments. Looking at this, make sure that you're looking and being very cautious for renal failure in all of your medications that you had except for your varenicline. This is the only one where it could be more, you're looking at your liver, and these are all renal, right? So renal and hepatic, renal and hepatic, renal and hepatic is also here. It's not listed here, but also here as well. So this one is the only one where you're like, okay, I don't really have to worry about renal, but I'm making sure that my hepatic function I am making sure that they have good hepatic function, because if they don't, that can be a huge red flag here. Renal function, not so much worried about it there. And then depending on your patient and how long it takes in them, so after their first time, they should know what's going on. They'll usually take it an hour or 30 minutes before they have sexual contact for the medication to actually be able to work. And remember, they only have, depending on which one they're using, 4 hours or that 36 hours for it to work, okay? So just keep that in mind on when they're going to take their medication. Here are some of our interactions, and this is why I was telling you we ask those questions, because you can have your patient, oh no, cut it off. You can have your patient, I'll repost this slide, because, well, I'm not going to ask you about that one as much. But understand, inducers we're worried about, okay? Inducers and inhibitors, that's all I need you to know here. Alcohol, because we have the hypotension that could also occur here. You can see where I'm further taking my patient whenever I'm giving them, if they're intoxicated and they've had a PDE5 inhibitor. Alpha blockers and your nitrates. So your nitrates, again, your nitrates are going to tank that patient, because you're going to have an increased risk of your hypotension. So your nitrates, your alpha blockers, your alcohol, all of these are synergistic effects in which you can see a decrease in their blood pressure that can be dangerously low. So if you are going to have a patient who comes in and for whatever reason you're like, hey, I need to give a nitrate because there's some type of ischemic event, cardiovascular event that's going on, then you need to ask this question, because depending on how long ago they took it and which one they took, you can see where you can have extensive hypotension occur, okay? Tadalafil is the one that we're worried about the most, because remember, that was the one that had that longer duration of action, whereas my other ones are like 4. So if I told you I took it yesterday and I'm 24 or 48 hours removed from the last time I took it, I'm not as concerned. But if it was my tadalafil, that matters. I'm still concerned. I'm still in the window where that drug is still working. And then looking at your alloprostadil. So this one is a prostaglandin, and what it is doing is it is vasodilating the smooth muscle as well. So what you'll see here is that the patient is going to be injecting themselves in their penis, and this is where I was telling you, for your patients who have like neurological underlying issues, that's whenever you're typically going to see this used. We had a patient who used to come and he was in a wheelchair, so he had a spinal cord injury, and this is what he used to take all the time. So we always just made sure we had his Caberdeck for him. I didn't ask him what happened to him, but this is what he was, of course, using it for. So again, if that is your indication, like if that's the patient's condition, you can try to give them those oral options, but they are likely to not work because of the etiology of their underlying condition. Looking at your starting dose, you're trying to make sure that they are tolerating the medication well, that they're responding to the medication well, that they know how to inject themselves properly. So this will be done with that first dose in the clinic. Your job. While y'all are making these faces. All right. And then you have your alloprostadil. So when you're looking at your alloprostadil, this one is a pellet. And so it only lasts for about 30 to 60 minutes, and it comes with this little tool, and essentially what they're doing is they are going to insert the pellet into the urethra of their penis, and they just push it down. But again, 30 to 60 minutes, so they gotta be ready for whatever they're about to do, because it's not gonna last for a very long period of time. Again, looking at your contraindications, so their anatomy matters in this situation. So you have some people who may have like Peyronie's or like a curved penis. If they have fibrosis for whatever reason, again, think about how you're trying to get your drug to the site of action, right? So if there's any tissue or any damage or extensive curvature, my drug may not go in the proper way, and I could potentially be causing more harm to myself. So that's why you see these listed as contraindications. They are not for those patients. So that is, again, going to be your job, because you're going to do a physical exam if you end up down this road where you're talking about an injection, or you're talking about somebody using one of these pellets. Okay? So very interesting routes. When we look at some of our other options for erectile dysfunction, you have your androgens that you can use, and then you have your non-FDA approved that we have. you're not going to recommend it. Just be cautious and aware that some people may tell you that they're taking Yohimbine for that. It's a herbal supplement, not proven to work, but some people say that it does. Female sexual dysfunction, something that we don't typically talk about, but our FDA has not approved androgens for use in women, but we do have one medication that is available called flibanserin, and it is a PDE5 inhibitor like our males. They don't work, and the dopamine and everything, we'll talk about this whenever we get to the next slide, but understanding that all of these things are not going to work. The only thing that we have is going to be your flibanserin or your Addy that is available for your women who have sexual dysfunction. That is it. All of these other herbals, all of the other hormonal therapy that you see is not approved for sexual dysfunction. So, when we talk about our Addy or our flibanserin, again, this mechanism is something that we are not very sure of. We think that it has effects on their serotonin and their dopaminergic activity. So that is the theory behind the medication. Clinical use for your premenopausal women who are not very sexually active, like they're not having the desire to have sex. Big thing with this is making sure that you're understanding why they have the lack of desire to have sex. So there could be other reasons, and then you start to get nosy and you snoop before you just prescribe, right? Are you having issues in your relationship? Maybe I don't like whoever my spouse is, and that's why I don't want to, right? So don't just think, throw a medication at it. Same thing for the males. Why do you have sexual dysfunction? Maybe you don't like your partner. Also could be an issue. Does that mean that the medication needs to work for that? No, that is you need to go to counseling and work on that, or find a new partner if you can. Sometimes we can't, right? So like, think about the underlying issue. It's not always immediately like medicine, okay? Medicine is not always the answer. Figure out what's going on first. And then not for your patients who are postmenopausal, and not for any males to be using this medication. Again, this is just for females. Males have all the androgens and everything else that we just talked about. This is not to increase their sexual performance. This is to kind of help with their desire to want to have sex, because they have that hypoactive sexual desire. Okay, so it's more so the desire. It's not going to make them like be fantastic all of a sudden. Adverse effects. Hypotension, you still see that here. You're going to also see some dizziness that's associated with it, depending on how they respond. And make sure that you're checking that baseline blood pressure that they have. Contraindication, very similar to what we saw previously. So if someone has been using alcohol, remember that the alcohol could cause that decrease as well. And then you see with your CYP inhibitors, we're worried about that. Don't remember about, you don't need to remember the dose. What I do want you to remember from this is that typically we will leave patients on this medication for about 2 months, and then we will reassess to say, hey, like, have you seen an improvement? Is this working? If they say that it's not working, then that means that it is a treatment failure. You can stop the medication and then try to, again, keep snooping for other underlying issues, other hormonal imbalances that they may potentially have. All right, let's take. All right, so these were off one. I shifted them. They're off one because I gave y'all this slide, and normally I don't have this slide in y'all slide deck. That's why. All right, so our medications and pregnancy. Essentially, your last lecture for Pharm, right? But when we talk about this, this is a review because y'all have seen these sometimes, and all of the other lectures that we've done, we'll kind of talk about some of these. This is just going to highlight the main ones that we've seen before. And then talk about treating different conditions in pregnancy. Big one being nausea and vomiting, and then we're going to talk about kind of how we treat that in those patients when they are pregnant. ELOs, same things that we typically see. When we're looking at evaluating the effects of our drugs, right? We want to make sure that we are doing no harm. That is our job, right? You want to make sure that you're prescribing a patient a medication that is not causing harm to them, and if they're pregnant, that includes another little human being, right? So that fetus. So when you're looking at this, just understanding introducing a medication at any time throughout that pregnancy can cause several different outcomes, and some of which are very bad. So that's why we have our pregnancy categories, And that is why it's your job, if you find out that someone is pregnant, or if you are thinking about prescribing a medication that could be potentially teratogenic to a patient, that you obtain a pregnancy test so that you are clear and free in your life. You checked, you did your due diligence, you made sure before you prescribed it that everything was fine. So this is just telling you all of the different issues that you can see occurring, some of which can happen from our medications that we put our patients on to treat conditions while they're pregnant, and some of them are just things that we find out when we're in our post-marketing of a study. You may see like, oh, somebody was taking this medication while they were pregnant and it causes adverse effects on that fetus, and therefore now we're saying, all right, we're taking this drug either off the market or we're saying that they can't use it if they are pregnant. So on this, just understand several different factors can play into what happens to that fetus when you introduce a medication to that child. This is looking at thalidomide and what essentially happens when we talk about, thalidomide poisoning. So what happened in those patients, they were treating mothers for nausea and vomiting. And when they were treating them, what they found was that they were coming out with these birth deformities. And of course, this is not what we wanted to happen. So we stopped using this medication. This is one of the first things where we were like, hey, this is a category X. This is something that we will not ever use or try to expose a pregnant woman to, because we had our children who were born with these developmental defects. So when we talk about the changes, we've seen this slide before several different times. All I want you to understand from here is that depending on when you introduce a drug, you can have different effects on that fetus. I don't need you to remember this entire chart. Just understand that drugs affect the fetal growth and potentially how they are born, if that pregnancy remains viable, because some of our medications that we have can also terminate a pregnancy, okay? This was our old way. So again, we saw this first pharmacy semester in our Pharm 1, and now you're seeing it again. So this is how you will hear people still, even though the FDA has gotten rid of this, refer to the pregnancy categories. So this is A, B, C, D, and X. A is like your best case, you have studies, you know that it's safe. X means absolutely not, under no circumstances would you give it to your patients. So when we were talking about like statins, retinoids, things like that, if we said, hey, if they're pregnant, category X, they're teratogenic, like don't give them to our patient. So just looking at some of these, refresh your mind on that, because you could potentially see this. And then of course the new rules that we have, so our pregnancy and lactation labeling rules, or PLLR. This is now what we are required to see on all of those package inserts that we have. So those long inserts that we see, also on the FDA website, you can find this. You can essentially look up any drug and it will tell you their PLLR rules that apply to that drug. So it has different subsections. So you have your pregnancy, your lactation, and your reproductive potential in your males and your females. So on some of your drugs that you look up, you may not see any information on your males, but 9 times out of 10, you're going to see your reproductive information on your females. So this is something that we're still seeing a little imbalance on, right? Because if I'm a male and I have a female partner and we are trying to become pregnant, I want to also make sure that that medication isn't going to affect my unborn child just as a female would. So that's where you kind of see where we're trying to get more studies that look at this. This would all kind of be like post-marketing type stuff that we would find out after the fact, kind of like a meta-analysis type of thing, a review, because we would never make a study that could potentially harm someone, right? And that can be one of those things where you're like putting a patient on a drug to see what happens to their child, which is no. So here are your main subsections, and then you have 3 subsections under each of those. So you have your risk summary, your clinical considerations, and then your data that is available. Looking at the PK changes that you can see in your women who do become pregnant. So when we talk about this, understand that the body is continuing to change as that fetus continues to grow. What the fetus requires is also continuing to change as the fetus continues to grow. So you'll see decreased gastric emptying and motility, so that's why we see a lot of constipation where the woman may start to eat less because like there's not enough room and just being uncomfortable. So again, this changes throughout the pregnancy. Your gastric pH can change, so thinking about that in certain medications that need an acidic environment for our absorption of that medication, that could also be altered. Your nausea and vomiting, just an underlying issue that we have in pregnancy. So if I have a lot of nausea and vomiting, if you're giving me certain medications, I may be throwing those up to where they're not effective anymore, right? Because I'm losing what is available in my body. So my F is starting to decrease and go down. So sometimes we'll try to give medications rectally. If it is bad enough, depending on what is going on with the woman, or if they're very dehydrated and they can't keep anything down, you'll sometimes have them coming in to where we'll give them IV fluids instead. So several different ways in which we can kind of bypass the nausea and vomiting to make sure that they're still being taken care of. Inhaled drugs and your IM delivery, just understand that you can have increased absorption in both of those routes, so that may mean that you can give a lower dose of that medication depending on what's going on. So think about also with your decreased gastric emptying and that motility, that now your drugs are staying in their body for a longer period of time, right? I'm not eliminating them the same, and things aren't moving as quickly as they were without my fetus in my belly, right? Looking at your distribution. So when we talk about distribution, you'll see that that total amount of water that they have now, it's going to increase, right? Because we have the baby and the baby's just floating around in your amniotic fluid. So you have more fluids that are on board. You can have more free drugs if they're bound by albumin. You can see that there's a decrease that can occur. So now I have more free drug. That means that now I have more drug that's free to do whatever its action is. So I may need to change a dose or decrease a dose whenever I'm looking at that. And then when you're seeing your body fat, over time you will see some patients where they will increase their body fat, and some patients may decrease their body fat if they're very sick throughout their pregnancy. So you can see this kind of go both ways. Make sure that you're also watching that if somebody did just so happen to come into your office, because you don't want them to gain too much weight either, because once that baby comes out, then they have to do the work to lose all of it. Looking at some other changes that we have, this is just looking at our SIP system. Like we always talk about, we have induction, we have inhibition. So just make sure that you understand that we can have increased or decreased metabolism of some of our drugs depending on what's going on. And then because you have that increase in that renal blood flow in your GFR, you can see where a lot of your medications, again, your F, your bioavailability may go down, because now I could be potentially eliminating it more often. So you know how if you see a lot of people, especially as they continue to go on throughout their pregnancy, they may go to the bathroom very, very frequently. Like they're always up and going to the restroom. That's also getting rid of some of my medications. So I may need to increase the dose depending on what's going on in that situation. Looking at drug transfer and that accumulation of drugs in the body when someone is pregnant. So all I need you to know from this is that if you have a patient who is pregnant and they somehow end up in your office, look it up, okay? There's no way for you to remember all of the different drugs and all of the different effects, and there's no way to keep up. Like medicine is fast, right? The basic skills that y'all are going to learn to be able to diagnose and do all of that is going to help you along and is going to get you very, very far. But when we're talking about medications and what's available on the market at that time, what new research or what new adverse effects have we had reported, that all changes the utilization of some of our medications. So always when you have someone who's pregnant, you don't need any liability issues. Just go and look it up. There's several different apps that they have. Even when someone is breastfeeding, look it up, because a lot of our drugs do cross the placenta, and some of them will be in concentrations that could be very effective and affect that baby, and some may be very, very minute. And I might be a mother who says, I want my kid to have nothing. I don't want them to be exposed to anything at all. So again, a conversation to have with the patient, and big thing from here, just understand babies can be affected by what their mothers take, okay? Look it up. All right. So, looking at our nausea and pregnancy, please pay attention to this part. These steps that are on this slide, you're going to see them again, for sure.
Alright, so for nausea and pregnancy, first things first is we're always going to try to treat with non-pharm. Non-pharm before we try to get into the meds. So non-pharm options are the BRAC diet, avoiding those triggers, correcting the dehydration that a person might be experiencing, and also just continuing those prenatal vitamins. And then when we're thinking about getting into meds, this is like in severe cases of nausea. We'll start with the simple stuff like ginger and B6, and we'll trial those for a week. If it's not working after a week, we'll then add doxylamine. Try that for a week. And then if there's no resolve there, then we'll stop all of those meds that I mentioned prior, and then we'll try an antihistamine. And that is just for nausea, so they haven't vomited or aren't experiencing vomiting. But on the other side, if a patient is experiencing vomiting, the chart on the next slide kind of gets into a little bit something else. Is are they experiencing the hypovolemia? If they're experiencing,
I'm not gonna ask
you're not gonna ask that. Okay, cool. But in general, for meds for pregnant women experiencing vomiting, we'll still start with the non-pharm options, and then go through the ginger, the B6, all of that, and then we'll add a dopamine antagonist, like a metoclopramide, promethazine, or a whatever. Yeah, right. And if the vomiting does not resolve with that, then we'll add a Dancitron. Yep. Trial that for a week. If the vomiting still continues, then we'll try glucocorticoids.
So, big thing here, I am trying my non-pharm first. What are the triggers? If it's smelling things, if it's eating certain things, avoid it. If I am eating large meals and it's causing me to vomit or to become nauseous, avoid it. I remember when I was pregnant, I'd be like, oh, I see something. I'd be like, oh, I want that. And I come home, my husband or mom would like cook all this food. I'm like, why does it smell like spaghetti? You told us you wanted spaghetti. Nope, gotta go outside. Have to wait until the smell is completely gone. Look at my toothbrush, that might cause me to throw up. Avoid the trigger, I couldn't. I have to brush my teeth, right? So you think about some of these things. There are some things where you can avoid them, but some stuff you may not be able to avoid them. So it's kind of like an up and down and trying to figure out what are you going to prescribe. So at your level, the most things that I have seen and the steps that we typically get to, and it depends because they can come back to you on anything, but this is like one of those things where you find out or you told somebody that they're pregnant, you'll start them on the ginger and the pyridoxine and a prenatal vitamin, and you're like, wait until you have your OB appointment. That's like their starter pack for becoming pregnant. It's like, congratulations, you're pregnant, here are these things, you might need this, okay? And that's kind of what we do until they can get to their appointment. And then these steps are a lot clearer and more simple in the way that I'm gonna ask you versus you looking at this. Because I'm not going to ask you about their volume status and all of that. Just understand, if somebody has been vomiting for a very long time, they come into you, and if they're looking like kind of like flush and just not great, then they will know what their protocol is. Depending on what installation they're on, they may tell them to just go back to OB, and they will hook them up to an IV, and they will give them IV fluid. I used to have to do it all the time because I wasn't eating or drinking when I was pregnant, and then I would get very nauseous and continue to throw up because I didn't eat or drink, and then IV fluids. So they were just like, you're doing great, keep it up, you're living here, okay? So if you have that happening, that may not fall on you to do it, but the patient may end up in your office for you to tell them, hey, this is where you need to go, okay? So these steps are just written out words, 1 through 6, of all of the extra things in here. This is way more in detail than you're going to need to know. So that's why I wrote out the steps on that other slide, which was not there before, okay? So natural first, add on your doxylamine. If you don't have any response, then the same thing that you saw in that previous slide, get rid of your medications that you have them on and then just put them on the antihistamine, and we're gonna see it again. So we don't have to go through this. Just understand nausea and nausea with vomiting or nausea without vomiting are two separate things. Nausea and vomiting is not the same thing, okay? So just keep that in mind and remember which ones are actually helping me if I am actually vomiting, which ones are helping me before I get to the stage of vomiting and I'm feeling nauseous, okay? And remember the order of these steps. If you want to see a picture, look at this. We always have to talk about that.
All right, your non-pharm options is ginger and pyridoxine. Key takeaway is they are used for nausea and not vomiting, and then pyridoxine has an adverse effect of sensory neuropathy and drowsiness. Next slide.
Don't remember any doses in here. I will tell you the dose that we need to remember, okay? So mechanism of action, don't forget your mechanism of action, and we're gonna just keep going like this, okay? So mechanism of actions are still your things.
And an option for pregnancy is the P6 acupressure point.
All right, so group 2, we're gonna take a look at combination med of diloxamine and paroxetine. So doxylamine is Unisom. It's a H1 receptor antagonist. It's pretty weak from what I was just reading about it. So when you use it depends on whether or not the patient has vomiting or non-vomiting with their nausea. It's a little bit lower down if they don't have the vomiting, and it's kind of like first line if they do have the vomiting. And then if it's still not controlled on that combo, then we're going to jump down to our other antihistamines. So there.
Hold on, real quick. For this is what he's talking about is the combination. So your pyridoxine with your doxylamine is diclegis that comes together, like it's one pill. So it's these two things together as one pill. Sometimes it is on our formulary, sometimes it is not. So that's why we just prescribe the two things together and tell them to take it, and we'll give them a pill cutter. They cut it and they dose themselves. They just take it at the same time. This is the way that we get around this prior auth on y'all's end. Have to do that.
So like I was saying, if that combo pill is not working, you're going to move on to a different H1 antagonist. So we had 3 choices: the dimenhydrinate or diphenhydramine or Benadryl. So you're going to want to discontinue at least the doxylamine part of the combo pill and keep taking the paroxetine, just because it's additive effects of the H1 antagonist. So you'd see increased sedation with that. And then meclazine's on there, but it has shown an increased risk of cleft palate in animal studies. So I'm assuming we're not using that.
You will see some people do it, not preferred. Let OB do it.
And then moving on to the dopamine antagonist, this one only falls on if they're having actual vomiting. It's not included in the just nausea algorithm. So promethazine and prochlorperazine are first-gen antipsychotics, actually. And they found that it helped block dopamine receptors, which stopped people from vomiting. Reglan is a dopamine antagonist as well, but it's also got gastric motility benefits, so it makes your stomach empty faster, so you have nothing to throw up. And then they all have risks of EPS symptoms with them just because of that dopamine blockage. Covered all of that.
You did this one already?
Yeah, I just kind of talked through the slides instead of asking you to switch them.
Okay. Let me make sure.
Oh, don't give Finnegan IV. Unless you can read it. It's a pain in the ass.
your chemo-induced nausea and vomiting as well. So your patients who are receiving chemo, if they have nausea and vomiting after their treatments, you can also see that we're using this for this because we're blocking the CTZ zone.
One more thing that reminded me that the hypotension, it's pretty profound peripheral vasodilator, so you will see hypotension with the use of the phenothiazines.
Okay, moving on to persistent nausea and vomiting. So Zofran, kind of already covered in the beginning slide, but controversial in pregnancy. ACOG labels this kind of a third to last, one of the last lines, especially in the first trimester, because it's been correlated to having some oral cleft associations and even septal defects, as well as QT prolongation, which has been shown to lead to torsades when used at high doses. So, yeah, controversial, no. Yeah, when used the first trimester.
So that goes for both of these, okay? So both of the drugs, same thing. Sometimes you can see where a patient may take like one or two of these doses, but again, not something that you want them to be on a lot.
Okay, for refractory nausea vomiting, you can use glucocorticoids, so methylprednisolone, hydrocortisone, and prednisone, short course, and avoid the first trimester.
And we know all of our adverse effects of our steroids through our lecture.
All right, reflux issues in pregnancy. So lifestyle modifications, number one, smaller meals, less spicy foods, and then elevation in bed due to laying flat kind of allows the stomach acid to flow more upwards towards the esophagus.
And then there's 4 options for Pharm treatment that they'll talk through.
Okay, so the 4 options from the previous slide are anti-acid, sulfate, H2 antagonists, and proton pump inhibitors. So for anti-acids, they are safe in pregnancy. Usually it's for intermittent mild symptoms occur. You will have some constipation with aluminum antacids, and then magnesium, you'll have diarrhea as a side effect. So I think of it as A, C, and MD. And then sulfate is safe, but it's not well absorbed, and it forms a vicious like paste. That's probably why it's not well absorbed.
And then, sorry, I didn't involve calcium. Make sure that y'all understand calcium and constipation also. This is like the GI lecture that y'all heard.
So for H2 antagonists, we have cimetidine and famotidine. Cimetidine has the most safety, and as you can see, it's excreted in breast milk. And then for your proton pump inhibitors, we have omeprazole, lansoprazole, pantoprazole, and these are probably safe. There's fewer studies, and they're also excreted in breast milk. So overall, go with your H2 antagonists over your PPI.
With this, research is changing on which one they prefer, the cimetidine or the famotidine. So you will see sometimes like this flopping back and forth because famotidine is getting more research, is gaining more research popularity. So you are seeing more patients being put on that famotidine than the cimetidine.
So for constipation in pregnancy, we're going to go the non-Pharm options first. So tell your patient to eat more fiber, drink more fluids, and exercise. If that's not helping, then we can give them some pharmacologic treatments, which are our stool softeners. Our bulk forming agents are most safe because they're not absorbed. They may give them some gas, bloating, and cramping. We can go after that. Stool softener, our DocuSafe we talked about before, is likely safe. Our osmotic laxatives are for refractory use. So that is our magnesium hydroxide, lactulose, and our PEG. And then our stimulant laxatives are not ideal. It should be limited in pregnancy, and also for refractory use. Possible electrolyte imbalances.
So that's because it's gonna stimulate and it's gonna start doing this, right? So if I'm doing this and I have a baby in my belly, that feels like contraction, and I don't want that to happen. So that's why you see where we may see some of those cramps happening depending on where they are in their pregnancy. Sometimes we'll try to avoid them.
Diarrhea in pregnancy, so dietary modification is the safest method. You can do fluids and electrolytes, so oral replacement therapy. Loperamide was not shown to be teratogenic in animal studies, but human studies are inconclusive, so we assume we don't use it. Note bismuth subsalicylate is not recommended in pregnancy, especially second and third trimester.
What's in this that I'm worried about?
Aspirin.
Aspirin, right? My salicylate.
All right. Looking at your NSAIDs in pregnancy, just understand that they're not safe to use, and Tylenol or acetaminophen is your drug of choice.
Okay. Today.
Good afternoon, guys. Welcome to Group 5, Cough and Cold Medicine Pregnancy. Yeah, sorry guys, it's after lunch. Let's get this. All right, starting with antihistamines, diphenhydramine, you guys already know, Benadryl. One of the most well-studied antihistamines during pregnancy is considered safe. Another first-gen antihistamine is chlorpheniramine. Yep, maternal use has not been associated with an increased risk of birth defects, so it's also good to use. For second-gen antihistamines, we have loratadine and cetirizine. Yep. That we have strong human data on. A large number of pregnant patients have used them without increased risk. So these are good choices as well, especially when a patient needs something less sedating. Moving on to our cough suppressants, we have opioid-based suppressants like codeine, hydrocodone, and dextromethorphan. So these require more caution. Prolonged use can lead to neonatal withdrawal symptoms. There was a large trial that linked first trimester opioid use to congenital anomalies. So these should only be used when clearly necessary and under close guidance. For guaifenesin, one study showed its use with inguinal hernias, so it could come with a risk. Lastly, benzonatate, it doesn't have enough safety data in pregnancy, so just avoid it. Happy holiday, guys.
Okay, for rhinorrhea, sneezing, and throat pain, so saline's good to go, nasal spray, irrigation are good as long as the water's clean. Decongestants, not so much. Oxymetazoline, phenylephrine, pseudoephedrine can all have negative impacts on fetal blood flow. Best avoided if during the first trimester because we don't really know what it's going to do. Short-term use after that, less than 3 days, can offer some temporary relief, but it's kind of a mixed bag is from what it looks like. Correct me if I'm wrong, ma'am. But we don't really know if it's going to be good or bad for the baby, so probably best to just stay away if you can.
So a lot of congestion will naturally happen in that first trimester. It depends on what's going on. Sometimes you will see where OB will say, yeah, you need it because the pressure can get so much for the mom. They're not sleeping, they're not able to breathe properly. I have had people, and I have also, where I took maybe a dose before I got on the plane because I was already congested kind of thing, but not something where we're taking it on a very consistent basis. And on this slide, sorry, just no preeclampsia.
Okay.
The treatment for preeclampsia includes lifestyle changes, labetalol or methyl-dopa for chronic hypertension, and labetalol, hydralazine, or nifedipine for emergent hypertensive control.
So pay attention to the words and when you're using this. So my chronic hypertension while I'm pregnant, you're gonna take me off of my normal meds and I can either use labetalol or my methyl-dopa. Whenever you're looking at like hypertensive control in an emergent situation, let's say their blood pressure spiked, they're in a hospital setting, or you gave them these meds to titrate themselves at home, that's when you see your labetalol, your hydralazine, your nifedipine being used in those situations, okay? So pay attention to your words or setting if you see that.
All right, takeaway from this slide is if pregnant PT has eclampsia, give a Big Mac so she can get through it. And Big Mac is strong drug, which is needed to be diluted. Again, it's a medical emergency, so we gotta give a quick loading dose. And if the vignette says patient got worse after Big Mac, counter with sweetened milk.
Counter with what?
Sweetened milk, which is calcium, gluconate, whatever.
Okay. So, our treatment, right? What are we talked about this already before. What were we trying to worry about and why are we giving the magnesium sulfate? To control the possibility of them having a what? A seizure, okay? So make sure that you understand what drug I'm using and make sure you're understanding the difference between what you're using to treat preeclampsia versus eclampsia. So I have on my mag, I'm running that. Even if I think that or if I know that a person may become eclamptic, you can see sometimes providers will still run this mag sulfate because they're worried about them having a seizure. They don't want to wait till the person has a seizure. So you can see that. And then if you give too much or if you start to see any issues, then you're going to reverse it with your calcium gluconate. Don't remember any of these doses again.
The next one we got HELP syndrome. This is a complication of preeclampsia. You guys see hemolysis, elevated liver enzymes, low platelet counts. For treatment, we got supportive care, prophylaxis, blood pressure control, glucocorticoids, blood transfusion, and consider doing it at term.
So this is if like things worsen for that patient, right? So this is like the very worst situation that you can see. We run out of some of the treatment options, so we kind of start throwing things at them, and then understanding if they're later in their pregnancy, most of the time we will try to just get the baby out and then treat them on without worrying about any indications for the child as well or for the fetus as well.
All right, next we have JDM, which is a type of diabetes that develops during pregnancy, essentially when placental hormones increases insulin resistance. So for this one, we're screening all expecting mothers, especially when they're in their 24 to 28 week of pregnancy. The risk of developing JDM will increase.
Don't worry about that. What am I treating them with? I'm going to tell you what they have.
Alright, so for our treatment, we have insulin as our preferred medication, mostly because this doesn't cross the placenta and it is, good for the baby. However, we will have, it requires frequent titration of the insulin due to frequent hormonal changes. So referral to a specialist will be recommended. Then we have other drugs, maybe the alternates, which would be glyburide and metformin. This will not be considered first line because they cross the placenta and then they lack long-term safety. So I guess this would be recommended when the patient refuses insulin or cannot tolerate it.
Correct. So second line, first line is your insulin. We saw this when we did our diabetes. So same exact thing.
Hello. Okay, so we have 3 slides for group 7 and they're kind of connected but kind of not connected. So we have neural tube defects. We know that folic acid is the main driver. So low folic acid drives these neural tube defects. There's 3 different types. But the big important part for this is that prior pregnancy with neural tube defects, 4 milligrams of folic acid daily starting dose 3 months prior to conception and take throughout the first trimester. That's a big recommendation.
And if you know someone's trying to become pregnant, we try to give them folic acid before they become pregnant also, so that it's already kind of taken care of in their system.
And going hand in hand with folic acid, we have our iron supplementation as well. That 27 milligrams per day is the recommended dietary allowance for iron in pregnant women. We have 3 types of iron supplements. They have a different percentage for each. And I think depending on how deficient they are, you're going to get the higher percentage. So lower iron levels give the higher percentage that ferrous fumarate. She said she is going to tell us they are iron deficient. We don't have to.
I will tell you they have anemia, and you will say, oh, what drugs do I have to treat anemia? And then you need to pay attention to your side effects. The biggest one is constipation and those black stools. So tell your patients about the black stools, because some people see it and they freak out and they think they may be bleeding, but it's just the iron, okay? Bless you.
And then this is a more generalized slide, so obviously you want to be aware of all medications you're giving pregnant and lactating patients, that a lot of medications can cross through breast milk. So just be sure to double check anything you are prescribing, make sure that they understand they cannot have certain medications when they are breastfeeding.
Alright, so we got antihypertensives. So if you remember our lifetime movie network, just go ahead and forget about those. Actually, 2 of them are counterindicated a few times. But yeah, we got our central alphas, direct acting, we got a lot of options. So the main thing is we can't use these for phosphocental issues, so it's not worried about that. And then start diuretics during pregnancy, but they can be used during conception if you've already started. The next slide, you need beta blockers, good for your growth. Next slide.
No, don't use.
Don't use.
Yeah, it's highlighted in green.
Yeah, green for go ahead and don't use it.
It's highlighted so that you see it, because some people the red on the leg. So no beta blockers, your ACR, same thing, avoid them.
Alright, next slide. We got our antacids, reflux. Basically we use everything except for the business, just beef or food, don't do it. And then obviously because this is salicylic, that's why I think this is generally saying we look at drugs on our pharmacopoeia and make sure it's good to go. And then avoid using sodium bicarbs for we're called fetal metabolic alkalosis. And then we talk about magazine times to know if it will slow or delay later induction. So if you're looking at later pregnancy, think about that as a side effect. Antifungals, again, fluconazole, beauty, just don't do it. Fluconazole is also a no-go. Again, this is just saying we have a lot of options. Just look at your pharmacopoeia before you're treating your patients, and then make sure we're keeping within that 7-day treatment for clotrimazole and conazole.
So the way to look at this is anything that's 7 days, you're usually okay, and these are going to be topical, like they're going to be creams that they're going to insert vaginally. Everything else, like your oral options, your quicker options, are not going to be acceptable if they're pregnant. So this is just telling you, like, hey, these are your 7-day options that they have. Some of these they can get over the counter and they don't need you for it, so just make sure that they don't pick any of those 1-day options that are available. And then everything else is FYI. Okay? So those are just for completeness for you to see later. I will look at possibly trying to get a review done, because I'm trying to get their review done for them, because they have an exam on Friday. And then I have to write your exam, and I will see if I have time to get a review. Worst case, I will post it